The goal of this little segment is a little bit what is we discussed previously in planning is level setting, to just to get everybody on board about some of the language, but also to give a couple of frameworks to think about things that you'll be hearing about. There's a lot of information you hear from a lot of different sources, and I'm hoping to give you a couple of frameworks to how to synthesize and think about what you're hearing. So some of the concrete things are what to do with the information, what does it all mean for your system, and how do you share with others. Hopefully by the end of the 15 minutes or so, you'll get a sense of answer to this. So there are many theories of everything, and now I'm adding yet another one. You know this comment that there's nothing as practical as good theory, and if you don't plan ahead, you may get scrunched, and we don't want you to get scrunched. Now, during the morning, we heard that having a plan at all is a good lesson learned. So maybe you've learned something. That's just one new thing, to just have a plan. Now, one thing I'm going to talk about is the difference between IT and informatics. IT is the gizmos, IT is the technology, IT is what you can do with the technology. Informatics is thinking about all this stuff as a system of information. You'll be hearing a lot about systems engineering. You heard Don as a systems engineer. Charles Picard will be here later to talk about systems of systems. And informatics focuses on data, information, and knowledge. I'll define those a little bit more in a minute. And people. Like they say in Soylent Green, remember, it's the people. And so informatics is what you should do. Now, how many of you are technologists, and how many of you care about people? I think most of you care about people. So you did not know, did you, that you were informaticians? And informatics is a horrible word. We've been suffering from this French, Russian-derived word for the last 30, 40 years. You may hear of it today as data science or big data. And this is all basically informatics. But the focus is on people. Say a little bit about so this is the informatics cycle. You've all seen this in one form or the other. Some sort of loop where there's stuff in the background, it gets in the foreground, data comes back, and it cycles around. I want to spend a little bit of time on it. Here's the information system you all deal with, the justice system, education, whatever. It gets projected to the screen, which, as you can see, is opaque because it's really hard to deal with. And here's the user who's kind of in analytic depression, suffering from having to deal with this Anglo-Saxon word deleted system. And you can see, unfortunately, it goes off into infinity. So this is the human factor side of things, where the user and the system interact. And then hopefully, data is brought back from this interaction and brought back in the back end to be brought back into the system. Now, there's three types of knowledge. There's implicit knowledge and explicit knowledge. The explicit knowledge, there's the data warehouse stuff you just heard about, so you can get predictive analytics and data mining and data science to be fed back into this thing. There's a scientific literature, like Washington State's Institute for Public Policy, looks at the cost effectiveness of many human services interventions. And then there's the expert knowledge that Brian just talked about. You all know who not to trust. You know which data systems not to trust. You know how to think about them. And most of that is not explicit, but sometimes you get a rule base or a knowledge base, like you just heard the Magi system, and that gets deployed and brought back in. So this is kind of the informatics cycle, the learning health system cycle that the Cantor Foundation is dealing with. Is one way of dealing with this in medicine. So abstractly, you see you can have the big data, data mining, natural language processing in the back end, quality improvement, program planning, decision support at the front end, human factors, patient safety, or the correlate, I suppose, in human factors is privacy, because that's the main harm, I think, that we can do, both violating privacy and having people lose their services probably is the harm. And remember, every information system causes harm, and we have a responsibility to minimize that. And there's an infrastructure of management, exchange standards, could be NEEM, it could be NISIA, vocabulary standards. We heard a question this morning. How do we agree on the word adult or child or care or foster or health, et cetera? You can have the electronic health record or electronic human services record, and then you have the technology. And I'm not going to go on here. So that's one framework, the cycle and kind of time. There's another framework that I use in our graduate classes in informatics that I call the Informatics Stack. You heard Brian talk about layers of software, and so these are kind of layers to think about, although they're really Russian dolls. So the technology is support all this stuff around it. You have data, information, and knowledge again, and the algorithms that use them. They are in the support of the different modules that then have to be knit together into a system that has to support workflow, that supports goals and function, that supports the people in the roles, that supports the organization within the world. If you have two organizations, you can have two of these things, not communicating, as it were, at each level. But also sometimes you can just define the organization as a meta-organization. So California State has a lot of stuff inside of it. And as you know, getting one county to work properly is no small challenge. So I'm going to go down the stack kind of quickly just to give examples of what this means. And part of this will be informed by work I do with Uma Alawalia or most of the work that they've done in Montgomery County. They want to take credit for what they've done. So the world is the world of the state, the world of accountable care, the world of healthcare, the world of human services. Montgomery County is a county within Maryland, which is within the state, the country within the world. Of course, Montgomery County in particular has like 130 languages and people from all over the world, so they actually have to think about the whole world as it is, the real world. Then there's the organization, however you define it, whether it's a single organization or, like I said, a meta-organization. The people, in this case, are kind of the internal to the organization. Here's the org chart. Now, if you're providing services to clients, they have, their organization is the family, right? And you have different roles within the family. Hopefully, they are not structured in an org chart. If a family was structured as an org chart, that would be a psychiatric finding, and you have to act on that, okay? So that would be a bad thing. Then the goals and functions. This is where your value chain comes in, or the log frame, if those of you are familiar with the logical framework from USAID. Inputs to activities, the outputs to outcomes. So the inputs are the clients, the money, regulation, staff, space, all that stuff. The activities are the program activities. The outputs are what the program did, and the outcomes are what they achieved, right, or what the results are. In Montgomery County, they are actually named and indicated on a website. Some of the prior pictures that you saw from previous years from the Steward of Change meetings kind of apply. Here's consumer, being consumer-centric. You hope that your program activities are that, and so you can actually locate some of the things from the pictures over there. Level down workflow, we represent with these swim lane pictures. I'm sure you all see. And by this time, your eyes start glazing over because now we're getting too technical, right? But and at the information system, this is where we start creating, hopefully, an integrated system. This is another layered system. This is from Baksiva and Bob Mays from when he was CDC officer in Ethiopia. And again, you see from technology all the way up to high-level function. But of course, the environment that you all live in is, here are all these county and city and state and federal modules, and here are the program activities that feed off of all this, as you heard Brian call them, spaghetti. And that's what we're trying to fix. Data, information, knowledge. So the data are the factoids. So 37. Now, is 37 a good number or a bad number? Right? Well, on what? What the hell are we talking about? So that's where the information is. If it's a sodium of 37, you're dead. If it's an age of 37, you're okay. All right? So that's basically it. So knowledge is what to do with that information. So you go to the ball game and you ask what's the score, 4-3, who's winning? The answer 4. That doesn't give you much of an answer. Right? So that was supposed to be a joke. The algorithm is what do you do with the data in the form. So 1 + 2 we know what to do with. As you know, there are two types of people in the world, those who count to 10 and those who don't. It's a binary joke that's tiny. 10 is binary. As Tamara says, if you're missing 8 fingers or something. So 1 + 1 is 2 in Arabic. 1 + 1 is 10 in binary. It's computers. And who the hell knows what to do with Roman numerals, right? So there's no algorithm for that. And finally, we get to the technology. This, if you can see this is the Google farm. And what you notice, it's pretty, it's blue, no people, just like you have at home, I'm sure. But we never get down to, we don't really get to talking to this level because we have enough trouble with this stuff. At each level, we have concerns, standards, law, ethics, evaluation that are particular to each level. So there are standards. So the HIT panel working for the ONC in the mid-2000s came up with these 6 levels of standards. So it's not just data and vocabulary. It's not just information. It's even not just exchange. It's who we're talking about, what are standards for privacy, and how do we talk about function. So these are all different types. What about law? There is different laws about organizations, and it's different about technology, et cetera. Ethics and morality and the responsibilities differ by each level. We don't talk a lot about what are our ethical obligations in building an information system just at the level of the information system. And finally, testing is different from evaluating information system, which is different from seeing whether or not you've accomplished your goals. So I think you've gotten a sense from what I've talked about is that there's kind of what you're focusing on up here, which is what you want to accomplish, which is different from how it gets accomplished. What's interesting here is that this is a community that actually cares about this layer. Most people in policy just focus up here, assuming that all this stuff can get done. You know it ain't going to get done unless you start thinking about how. So you have to be able to talk to these people. You may be some of these people, but you also have to be able to talk to these people. So you are at the line. And in fact, being able to talk to people and listen, when are you above the line and when are you below the line, becomes a very important skill. It's actually a clinical skill. When a technologist hears somebody up here using the word like database or web, they get very nervous because they have no idea if you know what those words really mean. And it'd be very scared if they think you know what they mean, right? They shouldn't. On the other hand, if this person starts talking about diagnosis and outcome, you should be very scared. You know what the hell, they know what the hell they're talking about. Mm-hmm. So you live at that border between what and how, which makes you an informatician. So you didn't know that, but I'm giving you a new professional title. You're all human services informaticians, which is a new field that you all have defined, and congratulations. So the last thing I want to bring you to is use cases, which we'll be talking about over the next couple of days. These are either personas or characters or human beings, or the American Health Information Community that ONC put together to help figure out interoperability in health has a much more boring definition. It's standards, architecture, certification, policy exchange. If you remember Marshall McLuhan, this is warm and this is cold. All right? So, and they went ahead and they developed 13 use cases, half of which are actually directly relevant to what you do here. There's public health in here, there's reporting, there's consumer access, there's consumer empowerment, all things that actually you care about in human services. However, what they produced was not necessarily the most trippingly over the tongue, shall we say. So a 40-page document for a use case, a little bit of a train track. The good news is that the use case scenario, the narrative, was only a couple of pages. And that's what we'll be working over the next couple of days. Now, why do we care about use cases? First of all, they actually map to this whole stack. Again, the technology is not really a central point. But the most important thing is that use cases are communication among us. So if I'm in Montgomery County and we agree on a use case, and I can say, let me see if I can define the cost effectiveness, let's say, for this particular use case of interoperability, that's something we can all use. If you're developing a system and you show how it works with a use case that we all understand, again, we understand where you're going. So it's communication, it's testing, it's evaluation, and touchstones. The purpose of a touchstone is to come up with what is harder than what substance is harder than another. It helps you to put a whole bunch of different substances in a common language and a common setting. So I don't know if you can see this. This is theories of everything. Everything's gone downhill since 1964. That was before the Beatles came to the US, by the way. Everything is my fault. This is the mother. Everything is your fault. That's the son. And everything would be perfect if I had a dirt bike. So I hope I've shown you a little bit where to put all this information, whether it's a dynamic or a static or the use case. A little bit about the stack. I didn't point out that it's a 5-minute tool to know whether you're dealing with a rational information system. If folks you're dealing with cannot articulate all 8 levels, they don't know what their system is. If you can see that they're inconsistent, if the bottom half is all about state regulations, the top half thinks it's all about consumer satisfaction, it ain't going to work. It's out of sync. Now, that's an opportunity for innovation. I'm sorry to use the word, I apologize. I have to tell me what the other word is. I can't think that fast. But anyway, it's a 5-minute check. And we've had 200 students creating and evaluating systems using this thing in about a couple of hours. So it's looking for consistency and coherence, and then finally using these use cases as a form of communication. So with that, I hope you have some tools to use and to think and to put all this into perspective.
As a young engineer, one of the mantras was every system is perfectly designed to obtain the results that it gets. If you want to change the results, you have to change the system. A lot of the issues that we face in interoperability are caused by the absence of strong financial incentives or aligned financial incentives. So payment reform to accomplish that is a key part of the story. So what would it mean to redesign the financial models and the payment systems to support and reward improvements in population health? Or in a nutshell, how could we pay for population health? I want to explore these questions with you, for a few minutes. Dan has given me 15. And it's plant some seeds for you to think about for some sessions that will be happening later this afternoon in the next couple of days. So the theme is pretty straightforward, and this is a synopsis of what I'm going to say. The healthcare system is transitioning from payment for volume to payment for value. Fortunately, the definition of value that people are using, the triple aims, includes of rewarding improvements in population health. The determinants of health, we've talked about more about that later, require that if you want to improve population health, you're inevitably involved in multi-sector efforts. That you have to have cooperation across many different aspects of the determinant of health. So there's a window of opportunity that exists because of this transition in the payment system to redefine how we pay for health and to create more sustainable funding models for improvements in population health. However, there's a big caveat here, which is that the complexity of the task and the weakness of the existing tools for doing it, particularly compared to the other dimensions of payment, the total cost and the patient experience, means that we're at a disadvantage. And there's a real threat that population health will not be incorporated in a meaningful way into these new payment models. And I think there's a real importance in having an awareness of the need for urgency and to create a placeholder for population health so that it has a proper role in the new payment systems as they start developing. So, outline, I'm going to give you a little bit of context and then examples of the transformational models of service and payment at the national level. I just spent 2.5 years at the Innovation Center at CMS. I have 5 minutes to tell you what we've been up to in that area. But I also wanted to talk to you about what's happening at the state and the local level in Vermont in terms of how one state is trying to put these pieces together into a coherent redesign of the system. And I've got 5 minutes to talk about 12 years worth of work in Vermont. And then opportunities and threats for the population health financing. So this is going to be a little bit of a whirlwind tour, so let's go. So the context, why delivery system reform? If you want to have universal access, you've got to do something about the cost problem. The main reason we have an access issue is the costs are unsustainable and the rate of growth of the cost for services exceeds the rate of growth of the revenues that we have to support that from a number of different sources. So the approach is transformation of the current system. And I want to emphasize the word transformation. You're not talking about incremental change here, tinkering with the existing. You're talking about transforming it into a new model that will deliver triple aim's outcome. Now, conceptual model that I found very helpful for doing that is Neil Halfon at the University of California, Berkeley. He talks about healthcare 1.0, which was the acute care system, 2.0, which is the coordinated care system, you get into medical homes and ACOs, but then there's 3.0, which is your community health system, which gets at not just acute care and coordinated care, but gets at the root causes in terms of determinants of health and population health. So we really commend this model to you and spending some time to understand sort of that evolution in that track. So, transformation. How is CMS, as one of the largest payers in the country, been approaching transforming the care? The CMS mission that was established by Don Berwick in 2011 was for CMS to be a constructive force and trustworthy partner for the continual improvement of health and health care of all Americans. We recognize at CMS that even though our principal responsibility was to the beneficiaries in Medicaid, Medicare, CHIP, et cetera, that we were directly responsible for, that we would not be able to get the care that was required to meet the needs of that population unless we transformed the system for everybody. So we had to do a collaboration with the commercial payers and other folks to transform the system for everyone, not just for our beneficiaries. The Innovation Center was created to identify, test, evaluate, and scale up new models of payment and service for the beneficiaries. It was funded by the Affordable Care Act with $10 billion over a 9-year period. But beyond the funding, the Secretary was also given the authority that if we developed a model, and if the actuary certified that it was working appropriately, the Secretary could scale it up nationally without having to go through intermediate legislation. That is a tremendously powerful authorization and stick. The approach that the Innovation Center used on the transformation was to try to create a series of models of new services and or ways of organizing services and new ways of paying for services which met providers where they were in the transformation curve. The reality of the existing system is that there's a wide dispersion of readiness and capabilities. People are just very different places. So that if you're a system, a healthcare system that has no experience in taking risk and managing a global capitation, then a bundled payment system which gave you a slice, a very narrow slice that you could focus on and get some experience in a more controlled way was a good starting point. If you're one of the systems in California or Massachusetts which have been using global capitation and risk for decades, then we had to pioneer ACOs, at the other end of the spectrum. So our intention was to have a portfolio of interventions, but no matter where you were as a provider, we could meet you and move you to the next step. If you take a look at the CMS website for the Innovation Center, there are now over 40 different models of innovation models that are being tested and implemented. So I'm not going to take the time, but I just wanted to give you a sense of the strategy and how we're trying to approach this. The measures of success that we use in those models are the triple aims. And it includes an explicit provision improving the health, keeping patients well so they can do what they want to, increasing the overall health of the population. That was built into all of the models that we were putting forward. I was the acting director for the group, the Population Health Models group at CMI. We had a major initiative focusing on the population health component. The main thing was developing measures, trying to make sure we had a robust set of measures for tracking population health. The existing measures tend to focus on simple clinical measures that do not reflect the overall health of the population. and to try to strengthen not just new models which focused on population health, but in the other models that we were testing, like the primary care initiatives, the ACOs or whatnot, to try to make sure that they had a stronger population health component of that. So we focused on our own models, but also collaborated with the other models groups. So that's sort of the CMS strategy. They have all these different models that are going out there and being tested. How do you put them together into a coherent program for change at the community or the state level? Vermont's been at this for a decade. It's a great laboratory for testing out healthcare reform, 600,000 people, 13 hospital service areas with no overlapping or competing hospitals. So there's a culture of collaboration which has really been helpful and enabled us to do a number of things quicker that other states have not been able to even dream of. So the service models, what have we done in terms of the innovation and how we deliver care? I like to think in terms of different levels of intervention. The atomic scale, the basic starting point for intervention is the practice, the primary care practice in particular. The next level up is the community, the neighborhood for the medical home. So at the primary care physician level, the blueprint for health is an enhanced medical home model that was developed and tested was piloted in 3 communities representing 10% of the population initially. It was revealed to be successful, and 2 years ago we started expanding it. As of today, 3/4 of Vermont's population is served by primary care practices that are in this medical home. So this is no longer a demonstration or a pilot. This is the way that things are done in the state. As part of the enhancement of the original model, they're developing community linkages to community programs such as smoking cessation, diabetes prevention, whatnot. So at the practice level, they're strengthening the ties in other programs. There's also a more formal structure for developing new models of intervention. The Sash is a residential-based program, support and services at home. It's now in 40 sites across the state, and I'm doing a time adjustment. Okay. In 40 sites across the state. And again, it embeds a nurse care coordinator and community health worker into the residence, where there's a senior housing project, low-income housing. They also do it in rural areas. So it's a very innovative model for providing long-term support services to a needy population. We've just implemented a substance abuse hub and spoke model for opiate dependency. One of these things at the next level, the community level, Blueprint for Health has a community health team, which is a resource for the primary care practices and gives them additional arms and legs for following through on what they're doing. And it's a community-based intervention. In the sake of time, the payment models, the primary care practice, the medical home, there's a capacity payment to each practice from all payers. It's an all-payer payment reform. So the higher, the more pay capability they have on the NCQA medical home scoring algorithm, the more they get a PMPM payment. It can be up to about $50,000 per physician per year. It's real money on the capacity side. The state has just gotten one of the state innovation model testing grants, testing awards, in which they'll be testing out the bundled payment model, a global budget model, as well as refinements on the medical home model. So that'll be a tremendous resource for them in moving forward. So that's an example of a state that's been working at a number of levels, a number of ways to try to transform the care system and changing their payment models. Just if you want to see some other states that are doing some nice work, Minnesota and Maryland, they're also part. Check out the State Innovation Models Award page and get a sense for what the states have been up to. So, where are we? So you've got this work that's going on. There's broad diffusion of language supporting improving population health. It's in the air. I mean, you hear people talking about it. There are new payment models being tested at scale across the country. There are new options that are being developed for resources, the hospital community benefit requirements of the ACA, where the hospitals have to do an annual community health needs assessment and intervention plan, the Banking Community Reinvestment Act funds. There are signs of regional markets aligning in terms of all the payers getting involved in aligned payment models. However, the delivery system evolution lags behind the rhetoric with a broad distribution across health on scale. And in particular, very few of them really engage in 3.0. So a lot of talk, a lot of interesting payment models, but that last step is a big hurdle. So some of the challenges for population health financial models in this environment, the other dimensions of value, total cost, patient experience, have a long history of being used in payment models. There's a lot more experience with them. People know how to approach them. They know the measures to use. They know the tools to use. The interventions are better understood in terms of knowing what to do. The accountability is more clear-cut. The other issue is that the tasks that are involved in changing to the payment model, which is you're having to manage total cost and manage the patient experience, is all-consuming. It's sucking up all the available oxygen. And there's just not a lot of capacity left over as you take a look at what people are dealing with. Also, the population health business case requires reinvestment of shared savings from multiple sectors. It's not just the effect that you're having on medical costs. When we put that opiate dependency program in place in the medical home, we're tracking the impact on corrections, employment, and the impact on kids being out of. So you have to, and that's part of the story. You have to be able to capture that as well. So it's more complicated. You know, it's actually improving population health is really challenging. It's intimidating. The determinants of health model is not readily understood by a lot of the people involved. There's a tendency to focus on the familiar, particularly on clinical services, the clinical piece, even though there's a recognition that the clinical care contributes only about 10 to 20% to the determinants of health. It's known, you can have more control over it, and you tend to go there when you can. Also, the portfolio of validated interventions for key risk factors, such as obesity, is thin. The reality is that we're still learning what works and particularly how to implement it at scale. The measures are poor. There's a lot of confusion between quality of care and population health. And people, when they say that they have a population health program, you take a look at what they're measuring, they tend, as often as not, they're measuring the quality. So the threat here, as I said at the outset, is the payment models for population health are still in the early stage of development at a time when the system is changing very rapidly. You know, population health traditionally has been funded by grants, by taxes, not by payment for services. Developing the business case for a payment model is fundamentally different from developing the case of whether an intervention affects the risk factor or not. And there's not a lot of experience in terms of that development of a business case for payment models. So the bottom line is that the risk, as I said at the outset, that these new payment models will be established without a meaningful population health component. And I think it's, if we want to get a system that, improves the performance and delivers on improvements in population health, that rewards and supports that, then there's a lot of work to be done in terms of, in a short period of time, in terms of creating these products and challenging that.
Hi, thank you. I am Heather Hahn from the Urban Institute, and I'm going to be sharing some early lessons from our Work Support Strategies initiative. The Work Support Strategies initiative is really a partnership of many funders and partners. It's funded by the Ford Foundation with additional support from the Annie E. Casey Foundation, Open Society Foundations, and the Kresge Foundation. The project management and evaluation components are done at the Urban Institute, and then there is extensive technical assistance from the Center on Budget and Policy Priorities and the Center for Law and Social Policy. And Olivia Golden, who has been leading the project from the Urban Institute, is going to be moving to head up CLASP later this summer, and so the management of the Workforce Strategies project will also go to CLASP later this summer. So what is Work Support Strategies? It is a multi-state initiative to simplify and integrate how states deliver the large work support programs like Medicaid and SNAP. It has 3 goals: improve families' well-being by increasing enrollment in the full package of work supports for which they're eligible, to help states deliver benefits more efficiently and effectively, and third, to share lessons learned to inform state and federal policies. So I'm going to give you a bit of an overview, a summary of what the Work Support Strategies project is. I'm going to tell you why did states commit to the Work Support Strategies project, what did states do in the first year, and how did they do it. So this is the challenge that WSS addresses. We think that work supports can help low-income families meet their needs, improve their outcomes, and stabilize their work. And health reform is really making the opportunities greater because states are preparing to add millions more adults to their systems. Yet many families do not receive the full package of benefits for which they're eligible. About a third of eligible parents do not receive Medicaid CHIP. About a third of eligible working poor families do not receive SNAP. And in child care subsidies, where the dollars are capped, it reaches even fewer. It reaches about 30% of eligible families, leaving more than 2/3 of eligible families without the child care subsidies for which they're eligible. Even fewer get continuous coverage because they might be churning on and off, and very few get the whole package of supports for which they're eligible. And we know that state policy, processes, and systems are part of the barrier that creates this challenge. So Work Support Strategies aims to integrate and modernize delivery of at least Medicaid and CHIP, SNAP, and child care subsidies funded through the Child Care Development Fund. Several of the states that are participating are also including TANF and other supports for their families. There's a 2-phase design, and the first phase is what I'm going to talk about most today because it's already been completed. There was a 1-year planning and piloting phase that 9 states participated in. Each got a $250,000 grant, which they used to leverage additional resources. They received extensive technical assistance as well as peer-to-peer support from other states. They conducted data-driven assessments, and at the end of their planning year, they developed a state action plan for how they would proceed in the next phase, which is the implementation phase. In addition to these concrete benefits or inputs for the planning year, there were a couple of intangibles. One was just having the opportunities to step back and think and plan and have that space to think about what they wanted to do. And then also there was the external accountability of the WSS management team pushing folks to continually focus on this project and what were they going to do. So part 2 is the implementation phase, which is a 3-year phase, which has already started. There are 6 states continuing in this phase, getting $1 to $1.5 million each, again, leveraging additional resources, getting that extensive technical assistance, continuing the peer-to-peer support. There's also an evaluation component. That's the part that I'm most involved in. There is an implementation evaluation, outcome tracking, and in some states we're doing an impact evaluation as well. And then a very important part of phase 2 is information sharing with federal officials. The states participating in the implementation phase are Colorado, Idaho, Illinois, North Carolina, South Carolina, and Rhode Island. And I understand a number of those states are represented here, so you might be able to get further information directly from the sources later in this conference. Each state has taken a unique approach, has slightly different specific goals and strategies But all of the states have been assessing and addressing issues related to these 5 domains. They've been addressing business processes, policies, technology and information systems, data analysis and use, and management and communication strategies, and how all 5 of these weave together. So why did states commit to WSS? There are several reasons. One is because the pre-reform systems weren't working. Another, responsive government is a widely shared value. So among the states, there are red states, blue states, and purple states. And elected officials in all of the states hear from their constituents about problems. They want to modernize service delivery, reduce complaints, get rid of antiquated bureaucracies. They want to reduce duplication and improve efficiency. So it's a widely shared value. States wanted to commit because the fragmented approaches are really frustrating for counties and frontline workers when each program has a different set of policies and rules and systems. And states believe that these improvements will benefit children and families. Getting families the whole work support package will help them move up on the job. Keeping children on health insurance without gaps will improve outcomes. And understanding families' needs all at once will help solve the problems more quickly. So this is a picture of the cycle, the broken cycle that motivated many of the states to participate. Families need help, but there aren't enough workers to help them. So there are long lines, and they can't process the applications. So families miss work, they lose their benefits, and they need more help, but there aren't enough workers. This is the cycle that WSS is trying to break. Let's look at what the states did in year 1. So year 1 was technically a piloting and planning year, but it was really a lot more than a planning year. These states strove to get some quick wins and move forward. In the first year alone, Colorado condensed its 26-page joint benefit application to 8 pages. South Carolina retained tens of thousands of children on Medicaid through express lane redeterminations. North Carolina piloted aligned certification in 2 counties. Idaho reduced churn by aligning certification and pre-filling redetermination forms. Illinois piloted new processes in 3 large offices, speeding up responses to clients. And Rhode Island tested and implemented same-day service to SNAP clients in Providence, its largest office. And again, each state had a unique story, but there were 5 common themes. They all seized health reform as an opportunity for integration, and I'm going to talk briefly about that later. They all elevated child care policy and practice. Child care subsidies were a required partner in this initiative, and they are often left to the side. So states were really bringing in child care policy and practice and moving it forward. States improved the local office processes to speed decision-making. They built new approaches to policy, particularly around churn and using data. They improved communication between state agencies and between states and the localities and counties in the local offices. And then, as I mentioned, they each developed an individualized action plan for moving forward. Because this symposium is focused on health and human services, I want to talk a little bit more about what the states did in this area. All states are taking advantage of the 90-10 match funds to make improvements in their health and human service systems. All 6 of the WSS states are doing that. Also, the core WSS teams in each state are tied into the ACA planning and rollout. So they're right there at the table together. Rhode Island and South Carolina elected to use ACA implementation as leverage to create single streamlined pathway to a package of benefits. How did they do it? I'm going to answer this question by focusing on the challenges that the states overcame or have tried to overcome with their various strategies. So the first challenge is using data for decision making. Very common among the WSS states and probably among many other states is that there is a data warehouse that has all the data in it, but you can't get the data out of the warehouse or use it to answer the questions that you need it to answer. Also, we heard there's just no culture of using data. So when the issues that rise up get handled and those that don't are not handled, and it hasn't been a culture of using data. So the strategy states have used, they've moved ahead with the existing data, they've built staff capacity to use data, and at the same time are investing in better data. Challenge number 2, modernizing technology. If you just apply technology to bad processes, you just have a faster way of doing inefficient things. So that was a quote from North Carolina. So what states are doing is they are using the technology to support the vision, not to create the vision. Technology is helping, it is not driving. They are aligning technology changes with changes in business processes, policy, and culture, and developing institutions and governance structures, such as committees and oversight, to enforce that alignment of technology with the vision. So challenge number 3, collaboration. Here we heard the problem is we were making the process hard, writing policies separately for each program. We also heard the biggest challenge is overcoming the turfism. The mere fact that they're separate entities is a challenge, but also the whole history issue. So here, when you have a long history of state agencies that don't speak to each other, there are no quick fixes. But these states have taken multi-pronged strategies. They've created clear visions and roles. They've attempted to change their behavior. They've developed new relationships and new institutions, and have really achieved those early wins together to help build that sense of collaboration. And then the 4th challenge, leadership and management capacity. These ideas of integrating and streamlining are not new. States have been wanting to do this for a long time. But what we heard was that the structure, the having regular meetings and following up and actually getting it done hasn't happened before. We also heard the hardest angle is on the ground. The management and leadership at the local level have to do the change. So as far as leadership and management strategies, it's really important to have strong leadership and management at many levels. So the local office agency manager needs to be a leader, as well as the department secretary. Each person needs to play their position well. And project management capacity can free more leaders to contribute. So what a lot of states did with part of the grant from WSS was to hire some people whose full-time job it was to keep this project rolling, to impose that structure, to have those regular meetings, to do the follow-up, to keep things moving, so that the leaders could contribute their ideas and their knowledge and their expertise, but weren't burdened with just the management of the project. But ultimately, turnover means it's never done. So there are some great sources for finding out a lot more about this besides your peers in the room. At the Urban Institute website, there's, if you Google work support strategies, you'll find it, but there's the link up there. There are reports. There's one report for a cross-cutting report about what happened with these, actually the 9 states during the planning year. And then there are individual reports for each of the states that go into a lot more detail if you're interested. And there's a brand new commentary collection that just came out last week of many different people from different perspectives writing about a page and a half of their perspectives on this project. And there is a forum coming up at the Urban Institute on June 24th that I encourage you to watch or participate in. Thank you.